Hello, everyone. I am Felix Su, the Director of Health Policy for Manifest MedEx. Good as always to be with you. I've lost count, but I think this may be the third or fourth webinar that we posted in our series on the California Health and Human Services Data Exchange Framework, or the DxF for short. Now, I'm sure we have a lot of returning attendees for this hot topic out there in the Zoom audience today. So for those of you who are the original DxF fans, so to speak, thank you for sticking with us for this far and this long. And those who are new to our webinars, to the DxF, and or to Manifest MedEx, welcome. We are so glad to have you join us, and you couldn't have picked a better occasion. Today's webinar marks an exciting milestone in that it is our first one following the official announcement of the inaugural set of Qualified Health Information Organizations, or QHIOs for short, by the state agency that administers the DxF. And as we shared publicly on October 25th, Manifest MedEx indeed has the honor of being designated as one of these QHIOs. So for many of you who are already participants in our network and have been asking us anxiously when we will hear about our qualified status, now that day has come. And the question for many of you probably turns to, okay, so I'm already signed up with what is now a QHIO. What does that mean for my organization in terms of what I have left to do when it comes to the DxF? If so, this is definitely the webinar for you. Now, many others might be curious in learning more about our MX data and services, especially after being prompted to explore our capabilities with our QHIO designation to support the DxF and its upcoming requirements. This is also the webinar for you. We're going to be going through all of that and more today, and I'll be co-presenting with my wonderful colleague, our Chief of Staff, Brittany Weppler. So first, our usual quick housekeeping items. All lines are muted except for mine and Brittany's to make sure that we get through all the important information we have for you today. You can and definitely should submit your questions to the Zoom Q&A box, where we will get through as many as possible during the dedicated portion after we conclude the presentation. And in the not unlikely scenario that everything that we cover in this hour might be a little fast-paced or a little much to absorb all at once, rest assured that we are recording and we'll be posting this session on our website, where you can relax, rewind, review, and most importantly, share this recording with your teammates and colleagues to help you make the best informed decisions on your technological choice of solutions to comply with and benefit from the DxF. So with that, let's kick off with our dust jacket bio for what MX represents and the capabilities that we provide. First and foremost, on the heels of our QHIO designation, you should know that even prior to that designation, we have been the largest nonprofit state health network since 2019. We've quintupled in this terms of the number of organizations that we serve. And we aggregate, normalize, and match raw data for combined records for over 38 million patients. This is paired with our ability to integrate that information with claims and clinical data for over 77% of those records, as well as sending real-time notifications for admit, discharge, and transfer notifications for monthly ADT events at the tune of 1.5 million throughout the state. So who are those organizations that we serve today? Our connectivity spans, again, throughout ambulatory providers in the thousands range, like physician organizations and medical groups and health plans. I also want to note that we have a long-standing and growing partnership with county health departments. We have statewide capacity, as you can see from this heat map, approaching near 100% coverage for certain key counties in terms of the residents whom we have records for. Importantly, we're not just about the quantity, but also the quality and security of all that data. We have two very rigorous markers for both quality and security, high trust, and our NCQA data aggregator validation, which I'll come back to later. And a huge part of our value to participants comes from two types of connectivity. One is what I like to think of as being intra-network in terms of our ability to establish data feed successfully for over 75 types of electronic health record systems and counting, which is a major reason why we are so able to quickly and successfully onboard new providers to begin sending and receiving data. The other is inter-network, meaning that we are fully plugged into e-health exchange and care quality, which together form what you can think of as being an interstate highway system of sorts for sharing clinical documents for care coordination across the nation. Now, all of these are items that Brittany and I will have a lot more to say about. They're vital to our mission, which states that we are here to provide healthcare organizations in California with the information that they need to improve care, enhance health, and lower costs. And some of these same characteristics and capabilities are also some of the key components of what was required for us to be designated as a QHIO. So with that, let's lay out our agenda. First, we're going to quickly review what state law requires in terms of exchanging and making data available under the DxF. We'll then talk broadly about what QHIOs are and how they're supposed to help the various types of entities meet those DxF requirements. And next, we'll discuss the unique benefits of choosing to partner with MX as your QHIO. And we'll, of course, go over how our tools and services can satisfy all the standards that every QHIO had to attest to go through the state's process for qualification. Now, we'll also openly discuss what MX additionally had to offer related to and on top of those qualification standards to be able to support our participants, not just to comply with, but to fully benefit from the vision and the goals of the DxF, as well as very closely aligned programs and priorities in our state and communities, such as CalAIM, public health modernization, and other programs that are meant to advance a healthy California for all. So my section in describing all of those strengths and capabilities that MX brings to the fore will be rather high level, but then I'll be handing it over to Brittany, who will hopefully breathe some real life into those examples by taking you through several of what we like to call our impact stories for our participants who have used the data that they received through MX to improve measurably the health and wellness of their patients and their clients and communities. Brittany will then explain how easy it is for your organization to also be able to get the most out of the data that's shared amongst the MX network. First, by onboarding with us, if you aren't using our network yet today. And second, by helping us, the collective network, secure a key DxF state grant funding opportunity that can go a long way towards sustaining our commitment to all of our participants as a QHIO. What is hopefully at this point a refresher versus completely new information for most of you, the DxF is made up of, well, what we understand to be a single statewide data sharing agreement. We call it the DSA for short, as well as a common set of policies and procedures, which are often abbreviated as the PMPs. Now, an agreement to do what exactly? Well, as codified in state law, it's to really exchange or provide access to health and social service information in real time for treatment, for payment, for healthcare operations, and for public health activities as generally defined under federal HIPAA regulations. Now, I'll try to put that in even simpler terms. If you sign the DSA, then you are obligated to electronically respond and send information that you hold or maintain whenever requested by another signatory for one of those HIPAA covered purposes. Now, Additionally, many types of healthcare entities were in fact required by that same state law to sign the DSA nearly 10 months ago on January 31st of 2023. If your organization falls into one of the categories on the left-hand side of the slide here and has not yet signed the DSA, either individually or as a subordinate of a parent organization, then you should definitely head over to the DxF DSA signing portal that the state has created for this very purpose, and take a relatively brief but important period of time to review the data sharing agreement in full, make sure you understand all of the provisions and requirements, and then enter the information into the requested fields to ensure that the state can record your organization's execution of the agreement. Again, this is mandated by the state law for many types of entities, and we are now quickly approaching the next major important deadline for complying with the DxF, which is not just signing the DSA, but to actively begin exchanging and making data available to other signatories under the terms, conditions, and obligations set forth in the PMPs. So that requirement becomes effective on January 31st of 2024, which I don't need to remind anyone is just short of 2.5 months away. Now, implementation and compliance, of course, is where the QHIOs come in. Now, this slide contains some specific language from the state's official educational materials on the QHIO program, which you can and should definitely review and make sure you're able to comprehend. For my part, I'll try to break it down in the simplest layman's terms. Firstly, QHIO is indeed a DxF specific designation. These organizations, including MX, have all applied for and have received that designation from the state for having met specific requirements for organization, privacy and security, and functional capabilities. Now, those application criteria either directly cite or are instrumental to the PMPs of the DSA, including but not limited to the technical requirements for how individual DxF signatories must digitally construct and both send and receive requests and responses for information. Now, are providers and healthcare entities required to join and use a QHIO to meet their DxF requirements? No. They can use any technology, network, or intermediary of their choosing, whether it has qualified status or not. In fact, your organization can even choose to use one or more individual, what we call point-to-point connections directly with another signatory's data systems if that fits the scope of your need to comply with the DxF. Now, in other words, QHIOs are really part of a broader landscape of data exchange options and intermediaries, which is depicted here in this diagram, again, from the state materials. So on this stylized infographic on this slide, you'll see that there are multiple QHIOs, just like in real life, and individual healthcare organizations, both large and small, that have agreed to, and in many cases are required to share data under the DxF, as well as nationwide frameworks, for example, care equality, that can also facilitate some important types of health information exchange. Look closely, and you'll notice that some of the signatories in this diagram are connecting with one or both QHIOs as well as the nationwide framework. And you'll also observe that all of the QHIOs are depicted as connecting to that nationwide framework. Now, we're going to revisit this shortly, but I first want to tackle the question that all of this begs, which is that if there really is a plethora of options, QHIO or otherwise, that can assist signatories in meeting their obligations to share data, then really what is the practical purpose or reason for why a signatory might consider going the QHIO route? To understand why, let's return to the original source of those DxF requirements. Again, every organization that signs a DSA must also review and understand the accompanying PMPs that govern the exchange of health and social services information under the framework. Think of this as familiarizing yourself with the basic rules of traffic before getting onto the freeway. Now, while that may seem like a daunting task for something like health information exchange, I can readily attest, as somebody who is neither an attorney nor a technology person, that these PMPs do not, for the most part, require any specialized training or knowledge to get through and to grasp the main takeaways. Now, we won't rehash every PMP today for the DSA, but for the purpose of understanding how MX as a QHIO is ready to support different types of organizations with their DxF requirements, we are going to focus here on this slide on the general type and content of electronic health information that many of your organizations are required to send in near real time when requested. So the DxF references a set of national and federally adopted standards that encompass what is known as the United States Core Data Set for Interoperability, or the USCDI for short. This is a defined set of clinical data categories and data elements. Think things like labs, procedures, medications, but also importantly, key demographic, social information, as well as information on a patient's care team, along with the technical formats and codes and standards for properly transmitting those elements so they can be successfully received, consumed, and acted upon, again, for those treatment, payment, and healthcare operation purposes. So if you're looking at this and you're thinking, oh, clinical data, that's only something that a provider signing the DSA needs to worry about, well, think again. Increasingly, health plans, which also must execute the DSA, also maintain large sets of clinical information for their members as part of their utilization management programs, their care coordination, quality improvement, population health, and other major types of healthcare operations. The DxF requires payers to share any such clinical data that they maintain in the standardized format according to the USCDI. And that's on top of the traditional administrative data that they're supposed to share, like claims and encounters, which you typically associate with a health plan. So does everybody working for a provider organization or a health plan that signs a DSA need to be an expert in all of these clinical data elements and standards? Of course not. But should anybody working in or around DSA compliance for your organization should you reasonably expect, AKA not have to worry, that a reliable intermediary partner like a QHIO should be able to deliver those elements and standards no later than January 31st of 2024? Absolutely, that is a reasonable expectation. And in fact, one of the key enhancements that MX has heavily invested in throughout the year is to make sure that our longitudinal patient record that's accessed by care teams and other participants features that fully expanded data set as defined by the USCDI. Now, this doesn't just mean that when you put out clinical data through your connection fee to MX to share with other DSA signatories, it doesn't just mean that your data will be DxF compliant that you're pushing out. Remember, sharing data is a two-way street. What you'll get back as a participant and user of MX requesting data for your own care coordination and quality improvement purposes, thanks to these enhancements, will be the full complement of all of those USCDI elements whenever they're made available by the responder on the other end, which includes more information that can drastically help advance health quality and equity for your patients and populations, such as social drivers of health, care team members, and where available, sexual orientation and gender identity. Again, the point of this example is not to claim that other types of intermediaries that do not have qualified status, whether they're other vendors or national networks or frameworks, point-to-point connections, et cetera, it's not to say that they necessarily cannot satisfy these types of requirements for exchanging elements and standards like USCDI. Now, some of those alternatives may very well be equipped to deliver all of those specs. To harken back to that previous slide, though, what being a QHIO does entail is a clear public signal that a particular intermediary has applied for, has been reviewed by, and vetted by, and has received designation from the state as having met these types of technical requirements for exchange, as listed in the PMPs for the data sharing agreement. So another key requirement under those PMPs is for the hospitals under the DxF to send ADT notifications for any panel of patients that's requested by another signatory. This, of course, is both obvious and necessary, since ADTs are the most fundamental yet critical type of signal needed for coordinating transitions of care. Now, just like any other entity, a hospital does not have to use a QHIO to fulfill its DxF requirements, and that includes sending ADTs, where and when they need to go when requested by another signatory to the agreement. But the fact is today that over a third of California's general acute care hospitals do participate in MX in our network, and many of them are sending us ADT feeds through our what we call our notify service. What this means practically is that instead of having to hunt and seek out an individual ADT connection point, facility by facility, instead, for many parts of the state, our participants can subscribe to these notifications for a whole panel of patients. Let's say if they're a clinic or a PCP practice, or an enrollment file of members who are eligible for enhanced care management, if they are, for example, a Medicare managed care plan implementing CalHHS. And they do this through MX by casting a wide net for the hospitals within their service area. In other words, what you're getting is person-centered, not facility-centric real-time alerts that can make the difference between successful recovery versus readmission for patients. This type of ADT infrastructure is a core required capability that QHIOs are supposed to develop and demonstrate over time. Now, today, we at MX already meet that bar with flying colors. At the same time, we are always working to expand our network, especially of hospital participation, so that that realized value from that ADT capability grows even stronger as intended by the DxF. Now, speaking of that user experience of data sharing benefits, this is probably as good a place as any to briefly introduce the three main ways that our participants interact with and use data from the MX suite of services. The first is our main web portal, which is how most of our provider participants both receive ADT alerts from MX Notify and also pull up that comprehensive medical history for the patient when they're preparing for or following up with an episode of care. We refer to this as this longitudinal record being embedded in our portal. We refer to this as being MX Access, which again will be populated with all of those USCDI data elements and categories per the DxF's requirements. The second way we provide data to our network is through supplying direct feeds that can integrate with a participant's EHR, their care coordination system, their population health platform, or even something as basic but effective as a secure file transfer protocol site. This is especially handy when a health plan needs something like a clinical data extract for HEDIS reporting. The third way that our participants typically consume our data services is through custom reports that we produce, which compile population level insights on health equity, on social drivers of health, chronic conditions, or even something as basic but important as the most up-to-date demographic and contact information to use in things like outreach campaigns for preventative health screenings or vaccinations. These are all data that fall within the DSA's permitted and required purposes for treatment, payment, operations, and public health activities. And while the PMPs don't mandate or stipulate that any signatory, including a QHIO, has to provide these types of products and services through these types of connections. We do this at MX because we've learned and recognized from our participants that such services do provide an immense value in the ways that they can be consumed, analyzed, and acted upon that are meaningful for patients and populations. So it's not just that we perform services that expand upon what the DxF requires and envisions. It goes the other way. We've also, now as a QHIO, have leveraged some of the criteria to fill in some key data gaps by taking full advantage of the wider ecosystem of information sharing that's been created amongst the providers that have signed the DSA. So alongside those ADT alerts, MX also provides what are called clinical care summaries. These are basically snapshots of the hospital medical record associated with an encounter, such as inpatient admission. And it'll include things like the patient's demographics, the discharge summary, the procedure notes, the vital signs, et cetera. Now, we provide these clinical summaries in our portal and through some of the data feeds on a push basis. For instance, a participant can request us to forward these types of summaries for the patients within 24 hours after discharge. Now, you can appreciate that this service has the potential to be a game changer for improving outcomes. But again, data alone without services is not helpful, and vice versa. Services without data is basically just a field left fallow. That's where our connection to and our use of the national networks and frameworks like eHealth Exchange and Care Quality really come into play. Now, these national networks are important for intermediaries like other QHIOs to be able to query MX on your behalf for data that they're permitted to receive under the DxF for purposes like treatment. In terms of reciprocity, our participation in care quality via eHealth Exchange also affords us the opportunity to bring in care summaries from various major health systems like Kaiser Permanente, Sutter Health, University of California, Dignity, which today do not directly participate in the MX network. The reason being is that under the terms of care quality, we are able to request and receive this type of clinical care data for patients who have previously been cared for at one of these other health systems or facilities and are currently receiving care at a hospital that is within the MX network. As a matter of fact, many of those other systems like Kaiser have already consistently been using eHealth Exchange to request records that MX holds for patients who overlap their systems of care. So taken together, this reciprocity is a major step towards forming a more complete health history enabled by the DxF and the QHIO criteria and capabilities. Kaiser alone represents nearly 10 million patients between Northern and Southern California. And the motivation for all of this connectivity, again, is the vision of the DxF being person-centered versus facility or provider-centric. So having said all of that, it's not just our capabilities that are important. Our dedication to the DxF being successful by becoming a QHIO is really born from our commitment, not to shareholders, not to venture capital, but to CalAIM, to public health, and other Healthy California for All initiatives. Helping our participants achieve success for equality, for equity, for affordability is our North Star. Not earnings calls, not raising capital, et cetera. To that point, we do not charge implementation or subscription fees for ambulatory providers like clinics or individual physician practices because our mission recognizes both the intense value and need for as widespread and robust participation in data sharing for these less resourced care teams, especially those in the safety net. You'll also see this distinction in the way that we view sensitive patient information as a resource to be simultaneously protected with the utmost controls while being seamlessly made available wherever appropriate and wherever it can enable better care and public health, not as an asset to be monetized. We have strict governance and policies in place, including our agreements with participants that limit the use of patient data to sharing for HIPAA-covered purposes, like improving care coordination and quality outcomes. Our not-for-profit business model to advance data sharing for these types of legitimate purposes is not built on the sale of aggregated data. So, which is to say, we do not sell either identifiable or de-identified data to third-party organizations like tech firms or pharmaceutical companies or AI developers or population health vendors or other actors who may be kind of out to use it for revenue generating opportunities versus this public mission. In terms of data privacy and security, the QHIO application requires the intermediary to achieve what is known as high trust certification on or before the end of calendar year of 2024. Well, the good news is that MX already possesses and has consistently earned this gold standard of industry security certification since 2019. We also, again, hold that NCQA data aggregator validation, which speaks to the quality of the records that we clean and match and deduplicate to the point where they can be used for HEDIS measure reporting without having to separately do audits or primary source verification. This saves a ton of time and burden for our participants, whether you're a health plan or who that needs to report on these measures, or whether you're a provider that's otherwise being hounded by that plan during your favorite chart chase HEDIS season. Now, while this NCQA recognition of the work that we do to maintaining the integrity of the data isn't a requirement to be a QHIO, it is nonetheless key to getting more accurate and better HEDIS quality scores for our participants, which is a common yardstick for how well the entire healthcare system, including and especially the safety net, like Medi-Cal and Covered California, is serving our residents across the state. Now, speaking of health plans, those who have been with us from the very beginning have been consistently contributing both claims and encounter information to really complete the picture for a true longitudinal record. Now, serving health plans and sharing that information with providers in this way is one of our distinctive strengths that we bring to support care coordination for things like accountable care organizations and CalAIM in Medi-Cal. So for instance, care managers on the ground can see whether their patient was actually able to fill their prescription following a hospital discharge. That insight is not visible from the EHR medical record alone. You need to look at administrative data like claims to see whether that prescription was indeed accessed and filled. So this is really, again, a very special and valuable differentiator for MX as a QHIO and also just as a nonprofit health data network for California in general. Again, we have statewide capacity to connect all forms of clinical and encounter data. Transitions of care, as we all know, are sometimes borderless, such as when somebody from LA County has an emergency situation in San Bernardino. Our network has never been geographically confined to a certain set of counties or jurisdictions or regions. And we, again, on behalf of our participants, tap into our extensive access to the clinical care summaries across the national networks and frameworks. So all of this combined, our nonprofit equity and quality-driven mission that we stand for, the depth and breadth and the airtight security of the data that we're stewards for, and the scale and sophistication of our technology for putting data to work means that we are first in class when it comes to any type of industry benchmark. Now, not surprisingly, we have also been first in line in many cases as a trusted partner for California's state health agencies to accomplish their own goals, which are often data dependent and data driven. Today, as a key example, more than 400 clinical laboratories submit electronic results to the State Department of Public Health using a single, secure, and streamlined system that was built and is operated and maintained by MX 24 hours a day, 7 days a week. This is an incredible feat of ingenuity and reliability in being able to have that type of quality assurance to normalize and integrate lab data and ensure that it's usable at a statewide scale. We were also one of the three selected participants in the Department of Healthcare Services consent management service pilot that is fundamental to their goals of data sharing under the CalAIM program. As part of that pilot, we built from scratch a consent management portal and partnered with two Medi-Cal plans as well as the whole person care program in San Joaquin County to test that infrastructure and communicate our learnings from both a user experience and patient comfort perspective. So these are, instances of our track record building, maintaining, and operating critical infrastructure on a statewide scale. I think it's just as compelling in a different and perhaps a more directly relevant way to hear about the success stories from individual MX participants on the ground, which Brittany will now share. Thank you.
Thanks so much, Felix. Hi, everyone. My name is Brittany Weppler, and I am the Chief of Staff here at MX. So I'm going to kick it off by highlighting a couple of our participant stories. This is just a way of showing current and prospective participants some of the ways that our current existing participants are using the MX network. So the first participant I'm going to highlight is ARIA Community Health Center. ARIA is a CalAIM provider and FQHC that has several locations in Central California. They're hyper committed to increasing access and improving the health and wellness of the underserved patient populations in their area. So they joined MX back in 2022 and utilize MX Notify, which are the real-time hospital event notifications, to basically enhance post-discharge follow-up and reduce unnecessary ED utilization for their enhanced care management population. And they're using MX Access, which is the longitudinal health records that have a combination of both clinical and claims data, again, for enhanced care management by being able to really aid their community health workers in their mobile clinics and allow them to engage with their patient population there in the rural areas. The second one that I want to highlight today is San Bernardino County Department Public of Health. So this is specifically around congenital syphilis. And in 2019, San Bernardino County ranked 7th in California for congenital syphilis, which is double the California rate overall and 4 times the rate in the US. So in 2021, they wanted to make this a big focus, and they piloted a project using MX Notify to basically provide real-time notifications when someone on their panel of pregnant women that have been diagnosed or exposed to syphilis have a hospital encounter. And the case managers were able to look through the patient's longitudinal records in MX Access and follow up with them, coordinate care in a much more timely way than they were able to do that before. That resulted in saving about 30 to 60 minutes per case, which is huge in that environment. And additionally, we're able to provide that documentation to CalReady. And they were able to close health equity gaps by intervening earlier and providing culturally sensitive healthcare treatments, making this just a better situation overall. And the final example that I'm going to share here is Aledade. I'm sure many of you are familiar with Aledade. They are the largest network of IPAs in the country. They expanded into California back in 2020, and even since then have experienced pretty significant growth. They also joined MX in 2020 at the same time as they were expanding into California with the purpose of using MX Notify, again, those real-time alerts to kind of track everything with their 35 participating practices. So that accounts for about 58,000 lives in California on the MX network here. So just a couple of examples of how they've seen improvement in their transitional care management. So 2 practices, which are de-identified here, saw both a 33% and a 37% increase in their traditional care, in their transitional care management. And Aledade really attributes that to the increase in ADTs that they have. And they're able to really look at that health information that is on the MX network and able to act on that accordingly. So those same clinics saw a 29% and a 20% decrease in ED readmissions over 3 years. And additionally, prevented ED admissions and saw a 15.5% reduction and a 26% decrease in ED reoccurrence. So seeing some really measurable outcomes there, which are always fun to talk about. All right, so I'm going to switch over and talk about how MX can help you to meet your DxF requirements and just kind of the steps along with that. And then we'll get into some talk about the grant process as well. All right, so I know we have a mix of both existing MX participants and prospective MX participants on the call, so I'm going to break it down into 2 very similar slides, but they have a few key differences here. So for existing MX providers, the good news is you're well on your way. You've already signed up MX participation agreement, you're likely already sending us data, and you're likely utilizing our tools today. So the process really for you is very simple. If you haven't already, obviously the first step is to sign the DSA, and then we'll get you working on a grant application, which I will highlight here in a minute. The next step is really just to confirm that the data that you are sending MX is the right amount of data, that you're meeting the DxF and DSA requirements. So in order to figure that out, you'll want to contact your customer success representative here at MX to ensure that you have the right feeds live, and then also chat with your EHR vendor to ensure that that CCDA feed is including all the right data types. And that's really about it. And then, if you aren't already, you can access MX's tools, but I know as someone who's already connected, you're likely already utilizing those tools today. Now, if you're a new participant joining the MX network, there's a couple of different steps. So the first step is really, again, the paperwork process. So that's signing the DSA, signing the MX participation agreement, and again, working on that grant application, which I will highlight here in a second. The second is to set up your data feeds. So this is basically the feeds that have that required information to meet your requirements. So this is something as simple as, for ambulatory providers, a CCDA feed that includes USCDI V2 data elements. For a health plan, this is going to be things like the eligibility file, the claims data feeds, and also clinical data if held by the plan. But we can help you to understand exactly which feeds are necessary. And then again, the benefit that you also get in addition to meeting these DxF and DSA requirements is that you have access to all these tools that Felix highlighted earlier, such as the real-time notifications, the longitudinal health records, and data services. Okay, so now we've mentioned grants a couple of times, so let's highlight the grant process here. Okay, so we are currently in round 3. So we can help you to get set up with grants right now. The application window closes in about a month here in December 15th. I'm going to highlight a couple different kinds of just like the levels of grant dollars that are available. So really this is looking like hospitals and SNFs, for example, are at a $50,000 level. Provider organizations, medical groups at $35,000, health plans $25,000, labs $15,000, and then other DSA signatories are at $25,000. Now, some may be eligible for enhanced funding, and we can help to kind of identify what that looks like for you as well. Okay, so I'm going to highlight what's called the QHIO grant. And as everyone is aware, there's a lot of new data elements that, like Felix highlighted, like SOGI and SDOH and care team information, and a lot of enhancements and work that has to go into getting everyone ready to comply. And MX specifically has invested heavily over the last year and made lots of financial and time investments to make this as easy and streamlined as possible for our participants. And we know that joining a QHIO or another organization or investing in your own needs to be able to meet this can be a really tricky process. And so luckily there are these grants available that can help the QHIOs to receive this funding to help to offset all of these costs. So there's 2 different ways that you can go about this. You are able to submit an application on your own. The preferred method is through an umbrella, where one organization acts kind of on behalf and submits an application with multiple organizations on that grant. It's a more streamlined approach. It takes the hard process off of the practice or the hospital or the plan, and really lets the QHIO manage the process, making this very simple for the organizations or the signatories to just focus on meeting the requirements. So just to highlight some of the things that these grants can and cannot be used for. So they can be used to offset QHIO costs. So that would be connecting, MX connecting to a signatory's EHR, and developing capabilities to perform the requirements outlined in the DSA and its P&Ps. So that's the things that I was just highlighting in the last year that we've done all kinds of big exciting enhancements to get ready for this. It can also offset signatory costs, such as the signatory's cost to connect to a QHIO or personnel for onboarding. Some things that it cannot be used for. So it cannot be used, MX cannot use it for ongoing HIE operations. A signatory cannot use it to purchase a new EHR technology or onboard to a non-qualified HIO, or changing from one QHIO to another, or even connecting to multiple QHIOs. So MX is really excited to be your partner in this process. We've been really involved in every step along the way, and we look forward to helping you meet your DxF and DSA requirements. If you're interested in learning more or joining us, please reach out to us at info@manifestmedex.org or visit our website at manifestmedex.org. And if you're a current participant and just want to learn a little bit more about next steps, feel free to contact your customer success representative, and we're happy to get you onboarded and meeting those requirements at the end of January, and get a grant to cover a lot of the funding as well. All right, now I know we only have about 10 minutes left, and I have seen that we have a ton of questions. So I think what we'll probably do is pick some of the ones that look like they would apply widely to this group. And if we don't have time to answer your question, we're going to take notes of all of these questions, and we will get back to you individually as well. So, okay, let me pull up these questions. And let's see, let's start with Felix. I think this is one you could probably take. Are the QHIOs all connected? And if not, when will they be?
Thanks, Brittany. And yes, I will certainly take that one. So it this harkens back to the emphasis during my part of the presentation on the importance of the QHIO application requirement, including a connectivity to the national frameworks of care quality. Again, this requirement that was set forth by the state wasn't just sort of random. It was really meant to basically create the infrastructure for a network of networks for the QHIOs to be able to query each other for information, health and social services information, at least for treatment purposes. And basically, again, leverage that nationwide framework, including the trust policies and the technical standards to, again, seamlessly exchange that information. So in that sense, because every QHIO has attested to onboarding onto care quality, either directly or through a national network like eHealth Exchange, in that sense, yes, today the QHIOs are able and should be actively querying each other for requested information. Now, that doesn't really cover the basis when it comes to ADT notifications. One thing that both the state agency in charge of administering the DxF as well as QHIOs directly have been hearing from our participants is what is to be done about hospitals that use one QHIO but not another. Facilities that are sending ADTs to one type of organization or intermediary, but not really having a pathway to make sure that they get forwarded or relayed to a care team that uses another type of QHIO. Well, the state agency, the Center for Data Insights and Innovation, they recognized this dilemma in part of the crafting of the requirements for QHIO capabilities. Therefore, one of the forward-looking requirements that is going to become effective sooner than it feels like is the requirement for QHIOs to share rosters for patients for whom they are going to be requesting to get ADT alerts for should that patient land on a hospital that is outside their network but is on another QHIO's network. So again, think of this as the same concept in a sense, at least at a high level, as the purpose of the care quality framework, and that it's not meant to be facility-centric, it's meant to be person-centered. And the way to do that is through this common agreement and this technological connection point for the intermediaries, the QHIOs, to be able to share patient panels and get notifications from one another. And that is required to be operational from all QHIOs no later than July 31st, 2024, next year.
Great, thanks, Felix. Okay, here's a couple I think I can just answer really quickly. Are there any additional fees for us to use MX as a QHIO and to access additional services? So in order to use us as a QHIO, no, there are no additional fees. To access the additional services, everything is included in your, when you sign a participation agreement. So that's access to our portal, to MX Notify, MX Access, additional reports and data services. As Felix had highlighted, we do not charge implementation or subscription fees to our ambulatory practices. We do have some fees for hospitals, IPAs, and health plans, but luckily there are some of these grants here available to cover some of those implementation fees as well. If you're interested in joining us, just reach out and we can talk through your specific scenario. Let's see here. When partnering with MX, does my organization have access to clinical summaries from the health systems that MX is partnering with? Yes, so when you join MX and use us as your QHIO, you have full access to the data that is on our network. So you are a full participant. And then let's see here. What do I need to do on my end in terms of technology to connect to MX? We can handle this one as well. Yeah, so really it just depends on your organization type, but it's a very simple process of, we will work with your EHR vendor. We've worked with over 75 EHRs at this point, and we will connect your data feeds. So for an ambulatory practice, this is usually really simple because we can usually work directly with a lot of the vendors. If you're a hospital or a health plan, there's a little bit more involved in it because we're doing direct data feeds to your system, but it's a pretty simple process with minimal requirements and just a few different types of data feeds to connect. Okay, let's see here. Felix, this one was asked a couple of different times. Do you foresee there being opportunities for additional grant funding after this current round? If you can look into your magic 8 ball here.
Yes, those things are notorious for giving inscrutable answers. Well, I think my response is unfortunately be about as useful as the magic 8 ball, in terms of, just it being speculation. We have heard, and I know that there are some of our colleagues from, again, the Center for Data Insights and Innovation on this call right now, that through their webinars and announcing round 3 of the applications, that they have really urged many of the stakeholders, the prospective DSA signatories who are looking for the possibility of support for onboarding and procuring technology to meet their DxF needs, to not sit and wait too much longer, because there are no assurances that after the anticipated close of this 3rd round, which is mid-December, as Brittany mentioned, that there will be either funding remaining in the current allocation that that state lawmakers have approved to support the DxF and its signatories, and B, whether there's even probably less guarantee that there's going to be a renewed push to again, allocate more funds after the close of the last round. So basically, that's a long way of saying, act as if this is the last go around, because very much it's being communicated by the state that it's a distinct possibility and you don't want to miss out. And lastly, there have been an uptick in interest and applications being submitted for these grant funds, understandably so, because among other things, the QHIOs have now been officially announced and identified.
Great, thanks, Felix. Okay, I think we have time for a couple other quick ones. And again, I just want to mention, if we didn't get to your specific question, we will reach out to you directly. We see quite a few account-specific questions, so we're happy to follow up with you after this and make sure you get all of the answers that you need. Okay, next one is it more efficient to apply under an umbrella grant, or can my organization apply on our own? Yes, your organization can apply on your own. Umbrella grants are definitely more efficient. We can get multiple organizations submitted under one grant, and the umbrella organization manages that process, which kind of takes the responsibility off of you. So I would definitely vote for the umbrella, but you can apply on your own if that's the route that you would like to take. And then we have 1 minute, so I'm going to do one other easy one here. There's a question of, do you have a list of everyone on your network? Yes, you can find our participant directory on our website. So if you go to manifestmedex.org, and I believe it's under network tab, you can see all of our participants there, or feel free to reach out to us and we're happy to send you an Excel file as well with everyone, even organized by county if that's of interest. So we're going to wrap this up now, and we'll definitely make sure to get back with you with any questions. And thank you so much for joining, and we look forward to hopefully supporting you as your QHIO.